Okay. So my name's Louise Coates. I'm an adult congenital consultant at the Freeman Hospital, and I'm just going to really start off this morning by giving you some general background about adult congenital heart disease, maybe help you understand a little bit about the range of patients that we see, the sort of things that happen to them through their lives, and the sort of treatments that we provide. So just to start at the beginning, really, congenital heart disease is the most frequent congenital anomaly that a baby can be born with, and we can see here that it overtakes all other systems of the body, really. And what it really means is that around 1 in 100 children are born with congenital heart disease. If we include bicuspid aortic valve, which is quite a common, relatively simple form of congenital heart disease, and that number is a little bit more than 1 in 100. It's more heading towards 2 in 100 children. And if we look back at the history of congenital heart disease, really prior to the 1940s, there was no real treatment for many of the conditions, and a lot of babies with complex congenital heart disease and moderately complex congenital heart disease simply didn't survive for very long. In 1944, the first operation, the Blalock-Taussig shunt, which was an operation that connected the aorta, connected the red blood to the pulmonary arteries, which in a lot of conditions doesn't get enough blood at birth, really changed the outlook for babies with congenital heart disease and allowed them to survive beyond that early period. And then over the course of the next few decades, more and more advances came in that allowed more complex surgery to be carried out. Obviously, the cardiopulmonary bypass machine was key to being able to operate on the heart whilst blood wasn't flowing through it, and allowed more complex conditions such as tetralogy of Fallot, and then subsequently transposition of the great arteries where the aorta and the pulmonary artery are coming off the opposite ventricle to be repaired. I suppose as we've headed now to more recent decades, there are even newer technologies coming in, and those are things that we can do by catheter procedures. So replacing valves, you can see at the top right hand corner the transcatheter pulmonary valve, which was the first valve to be replaced by a catheter means, so putting it in through the groin, feeding it up to the heart and expanding it in the area where the new valve was needed, and also closing holes in the heart. You can see at the bottom an atrial septal defect device that is now really the routine way to close holes between the atria, the two top chambers in the heart. And as a result of this really very rapid and transforming development in surgery, and also in parallel intensive care and the more routine use of antibiotics to prevent infections, it resulted in many of these children who in earlier times weren't surviving, then surviving into adulthood, and then staying as obviously then aging within the adult population. And so if we look in 1980 at who was our population of patients with congenital heart disease, we can see that the vast majority at that stage were children, and with a few adults coming through. Now in 2016 there, and we're now obviously 10 years on from that, the adult population is now larger than the childhood population, and that adult population is continuing to grow because it's stretching out this way, if you can see my cursor there. Sometimes, of course, congenital heart disease can be diagnosed for the first time in adult life, and there are conditions which aren't, although less so nowadays, because most all babies will be scanned in the womb, and the vast majority of conditions will be picked up just by routine obstetric scanning. But still, conditions can present in adulthood, and on the left here you can see coarctation of the aorta, which is the aorta coming out the heart, this narrowing in the aorta, which sometimes cannot present as a problem in childhood and present later as an adult. On this side in the middle, a rare condition where the right ventricle and the left ventricle is swapped around, but because the right atrium and the left atrium and the pulmonary arteries and aorta are in the correct place, the blood actually circulates in the normal way, and it's only really when the right ventricle runs into trouble as the patient gets older that this condition can be recognized. But it equally presents in childhood, this condition as well. And here on the right, something called Epstein anomaly of the tricuspid valve, where the valve, the tricuspid valve on the right side of the heart is much lower in the ventricle, leading to a much smaller ventricle, but a normal circulation in terms of the connections. And as I already mentioned, we expect, and we continue to expect, really to 2050, our population of adults with congenital heart disease to continue to increase. And this is based, sort of predicted data based on Freeman data. We're now around 2023, and this is these are our Freeman clinics. We have around 4,000, just over 4,000 patients in our clinics. We're also aware in adult congenital heart disease that there is a population of patients who may have been discharged in decades past as children, when it was not sure, or it was assumed that everything would be fine. And also the patients sometimes get lost to clinical services during transition phases when they're going from pediatric to adult services. And the fact that adult services really have only developed over the last 20, 30 years, we know that there's a population of patients in the community who may not be under routine clinical follow-up, and these patients sometimes can present to the clinical services with complications later in the day. We know with the increase in adult patients that there's also increase in healthcare utilization, and this is a paper from the States, but basically reflects the fact that we're seeing increased attendances at A&E. We know that they also have higher rates of attendances at the GP. And down the left, we see a range of congenital heart disease conditions, from the simple at the top, the atrial septal defect, to the very complex at the bottom, what we call the Fontan procedure, or those with cyanotic congenital heart disease, which means that they have low saturations, blue blood circulating through their bodies. And when we look at this this chart, we see across the top the age of the patient, and how we could compare these conditions to patients from the general population without congenital heart disease. So if we look at, let's say, a 40-year-old with an ASD, we would expect them to have the same life expectancy as somebody with the same condition without this condition in the general population. When we look down at the patients with complex congenital heart disease, we can see that patients in their 20s with these diagnoses have the life expectancy of somebody who is really 50, 60 from the general population. And we know that one of the key things that causes early death in these patients is heart failure and reduction in function of the heart, and other complications that can be related, such as rhythm difficulties. But we also know that if we think back to the sort of slide of the history of congenital heart disease, that patients can be on different trajectories through their lifetime. And so in tetralogy of Fallot, we can see 3 different trajectories where patients develop issues during a lifetime, maybe indicated by the arrows, and eventually will die at some point. And people can be on different trajectories. And in the past, this is something that has been really influenced very much by surgical approach, well, disease severity at the time of birth, but also the intervention of surgery to modulate that course. This condition, transposition of the great arteries, where the baby's born with the pulmonary artery coming off the left ventricle and the aorta coming off the right ventricle, initially was repaired by a procedure called the atrial switch, which meant that the atria was switched to the opposite ventricle to enable the circulation to function. As these patients grew older, the right ventricle, which was supporting the blood flow to the aorta, started to fail, and we see that this can cause problems and earlier death. Now babies are repaired by something called the arterial switch, and we can see from these curves that the trajectory through the lifetime is much better. This operation really started in the 90s, so we don't really have a good we don't have any experience with these patients in their 50s or 60s yet, but the projection is that it will continue better than the previous operation. And so surgical intervention makes a lot of difference to trajectories for patients. But I think we need to think about other things that make trajectories different for patients, and that's really very much the setting for the talk today. I know people tend to sort of get very confused with congenital heart disease and the different conditions, the complexities of it, and I want to just try and give some sort of idea of how we can maybe think about it in a more simple way. This is a table that has recently been produced in American guidelines, and we don't really need to look at the detail of it too much, but just to say that I guess the function for patients is determined not just by their anatomy, but also by their physiology. And so even a patient with a complex condition may have a very well functioning circulation with no arrhythmia, no effect on other organs, and no symptoms, whilst a patient with a simple defect such as an ASD can have very complex complications if, for example, they have significant arrhythmias or they have pulmonary hypertension as a consequence. So we shouldn't just consider anatomy or the name of the defect when we think, is the patient or the person with congenital heart disease got something that we consider severe or something that we consider mild. We should also consider the physiology or the effects of the heart condition. And then another way that I think, if we do just think about anatomy in the first instance, is how can we simplify all these really complicated conditions where everybody has something slightly different, and we don't really have two people quite the same. And I think the way to think about it is basically, does the person with congenital heart disease have a repair that means that they have two pumping ventricles like anyone with a normal heart would have? And there are many conditions that are repaired in this way, so tetralogy of Fallot, transposition of the great arteries, pulmonary atresia, and so on. And if they have a two ventricle heart, then basically we can consider them quite similar, although there are some differences, but generally similar for the purposes of things like exercise, to patients with normal hearts who may have acquired heart disease and heart failure. At the bottom then we have two other conditions that are different and need to be considered as different, and those are with cyanotic congenital heart disease and those with Fontan circulations. Cyanotic congenital heart disease is often seen perhaps when the defect is unrepaired, but when there's right to left shunting essentially, so the blue blood is going across from the right side of the heart to the left side of the heart. It can also, it's not quite the same thing, but Eisenmenger syndrome, it also sees right to left shunting, and patients with reduced saturations do have a different physiology and need special consideration and I guess advice and interaction with the adult congenital teams who look after them. And then we have something called the Fontan circulation, and the Fontan circulation is a series of operations leading to the sort of arrangement you see here, which is done for, again, a variety of conditions where the heart can't be repaired into a two ventricle circulation. And that means that the patient basically has a single pumping chamber that pumps the blood to the aorta. And connections are made such as so the SVC and the IVC blood direct straight into the pulmonary arteries, and on this side there is no pumping chamber. And I'm going to talk about that a little bit more about the Fontan in a second, but I think just to say that if we think of the different anatomies, again starting with here we've sort of left out the milder types of congenital heart disease, such as ASDs, which we would expect to have, really, unless they've got complications such that I mentioned before, we'd expect them to have exercise capacity that really mirrors the normal population in general. We do see that there is a range of exercise capacities that are associated with the different defects, with the very complex defects here at the bottom, the Fontan, the cyanotic congenital heart disease. We have ASD late closure here because they're basically referring to probable Eisenmenger syndrome or or right heart failure in this context. And then the less complex conditions up at the top, which have been operated. And so we do expect people who have Fontans, who have Eisenmengers, and have cyanotic congenital heart disease to be generally exercising at a different level to those with more moderate defects. Now, coming back to the Fontan circulation, which I just showed you up here in the bottom right, this particular arrangement and repair causes a very different physiology to what we see in the normal biventricular heart. So in the normal biventricular heart, we know that if you exercise, your heart rate increases, your stroke volume increases, your cardiac output increases. In the Fontan circulation, you can see here we have a single pumping chamber that pumps blood round the body, and then that blood comes back to the pulmonary arteries and back into the heart. You can see here that this is dilated, and that, if we compare it to the normal heart, and that's because systemic venous pressure, blood stays in the veins of these Fontan patients, and it's that passive flow that enables it to get through the lungs. So it's really the lungs that act as the barrier to it getting into the heart. And if the resistance in the lungs increases, this can cause pressure to build up here. It can cause flow to be reduced into the heart. And the Fontan circulation behaves differently in exercise to the heart with two ventricles. You can see on here how the heart rate increases in the normal heart in black and the Fontan heart in red in a patient when they're exercising, and it increases as a mechanism to try and increase cardiac output, but actually we see a fall off in stroke volume because it doesn't help blood get to the other side of the heart. Nevertheless, we do know that in the Fontan circulation, exercise is really the only thing, although there are trials in these patients are small, but we do know that it's really the only thing that actually does improve function and outcome for these patients. Various drugs are tried, but we don't really have good evidence that they work. Ultimately, when the Fontan circulation fails, which is the inevitable consequence of this behavior of the heart over years and years and years, transplant is the main thing, the main treatment we have that we know can be very successful for patients. But delaying transplant, although there is a different response to exercise in these patients, it is the one thing that improves. Improves, has been shown to improve some outcome in some ways. Importantly, in adult congenital heart disease, there are often lots of other things going on, and congenital conditions can be associated with other congenital conditions such as chromosomal conditions, commonly Down syndrome. When the heart is not functioning as well as normal, it can cause back pressure on organs, and particularly in the Fontan circulation, such as the liver. Patients can have chest wall problems and restrictive lung issues that can be related to previous operations. And the consequences of childhood surgery and living with congenital heart disease can, for very many patients, cause significant psychological issues. And then on the background of all this, we obviously have to consider population health, and the things that affect the whole population also affect those with adult congenital heart disease. We know whilst we've had very good success in reducing smoking in the general population, obesity rates have been increasing, and the consequences for patients with adult congenital heart disease really of obesity is that it exacerbates further the cardiac problems they might experience. So it increases the risk of arrhythmia, it increases the risk of high blood pressure, and it may, in the failing heart as well, cause an extra burden for patients to deal with. And as I mentioned before, we do know that a lot of, I guess, attitudes to exercise, and also experience of exercise, has often come from experiences in childhood, and how children maybe have not been able to take part in school games or in activities in the same way as other children, or have often felt that they are different to other children. And that's a feeling that's reported by many adults with congenital heart disease, as feeling different to peers, and obviously having the extra anxiety about their heart that can go with that. Interestingly, it's also been seen in adults with congenital heart disease that people experience their condition in different ways, and that for some people it can really be everything about them, and that everything they do, everything they take part in, they're always thinking about their heart. And this can be associated with more psychological symptoms, but also more interaction with healthcare. Other adults can try and put it to a side and almost ignore it, and sometimes these adults are the ones who present later on with symptoms that have become quite evolved. And then, you know, perhaps the most common thing is people just accept it into as part of their life and just get on with life, but in a way that is sort of constructive. They come for their clinic appointments, they do their tests, and these things. And then there are some who having it actually is very positively empowering, and actually very much determines how they do things in life. They may take part in patient organizations and different things. So I think a functional disability, or whatever we want to call it, sort of exercise intolerance, or ability to carry out activities or exercise in congenital heart disease, is due, yes, to the condition itself, but it's also due to deconditioning. In very many respects, sometimes these are population effects. So we all know we have more sedentary lifestyles. We know obesity is on the rise. But also historically, due to restrictions that have been placed on them by us as doctors, sometimes by parents, sometimes by teachers, and sometimes by themselves. And I think in adult cardiology, adult congenital heart disease has often been sort of kept aside with pediatric cardiology, and not often incorporated into the wider things that are going on in adult cardiology, such as cardiac rehab, because they're seen as a different group of patients. But we know that these things in the middle are things that we can change, and that they should respond to intervention. There is a good Cochrane review, which is interesting to read for anyone who is interested in this area. Really, the trouble with many studies in congenital heart disease is they're based on very small numbers, small groups of patients, and there's limited evidence about what interventions are the best and how to provide them. But I think one of the key messages is that exercise is safe for adults with congenital heart disease, and it's safe whether we put them on the bike or the treadmill in a formal way in the hospital, which Deepa is going to talk about next. But it's also safe in the community. There may need to be some guidance and some advice which needs to be individualized around for different individuals, but generally it is something that it should be encouraged, and it is something that improves outcome, not just because of the effects of the physical effects of exercise, but also because of the psychological and social benefits of exercise. This is a big multi-centre study that we're presently taking part in, that really looks at patient-reported outcomes in congenital heart disease for adults with congenital heart disease. And we can see that the cardiac side, the side that is, I guess, what we call the disease itself and the complications of that, actually is a small portion of what affects how somebody experiences the outcome of their condition. All these other things, which are the things that affect all of us in life, are the things that determine how we experience things. And I think physical activities up here in the green is key, and lifestyle intervention, along with this support of the psychological side, is things that we can intervene on, help and modulate to improve how people live with congenital heart disease. So I think at the moment, this is from some work we've been doing over the last year, interviewing clinicians who provide outpatient care to adults with congenital heart disease. At the moment, we have quite because it's grown up out of paediatric cardiology, adult congenital heart disease expertise has been very much focused in the tertiary surgical centre and the specialist centre, with the congenital heart disease specialists holding most of the knowledge, along with the specialist nursing team, and the patient holding quite a bit of knowledge themselves, but often somehow being frustrated because the GP doesn't seem to know so much about their condition, and maybe if they go to an A&E in another hospital, things, again, there's sometimes confusion about that. So part of, the purpose of today and the purpose of the network in general is to provide that education and to try and change this model of care to a more integrated care that's integrated more with community teams and teams that are local to the patient. On the right here, you see a sort of a model that's used in other conditions that can be chronic throughout life, such as diabetes, such as cystic fibrosis, where the patient really acts as the one with all the knowledge, because it's not really just about the disease, it's also about all those other factors that are important to outcome, about psychology, about work setting, about school settings. And the healthcare is really there to provide a more individualized, I guess, flexible type of healthcare which the patient can engage in, and the local teams have a better awareness of. So this is the network. At the moment, the specialist centre sits at the centre of that network, and it has various roles, the specialist centre. And one thing that's important is that the specialist centre is always there for 24-hour advice through 7 days a week. Now, out of hours, that may be the adult congenital consultant on call, but in hours we have a specialist nursing team who are extremely helpful, know very well all the issues that relate to these conditions, and are an important point of contact if people ever have questions. The wider network, of course, and is part of today, is to deliver that education, the pathways, the governance around how we can improve interventions such as cardiac rehab in the community for our group of patients. And there were some standards, quite old now, but really that informed the development of these networks. And we can see that there are different networks across the country covering each region. This is our region in the red, with the Freeman sitting as the surgical centre, but we know obviously that there are many other centres across our region of differing levels of cardiac expertise. So just to conclude, with increased survival of children with congenital heart disease, we have a growing and continuing to grow adult population. We need to think of that adult population not just in terms of their cardiac disease, but also extra cardiac conditions, the psychological effects of living with congenital heart disease, the way an individual views their condition. And the disease burden then shifts away from the operations that improve the outcomes with the heart, and if we think back to those trajectories, but the acquired things and how we can change the trajectories in a positive way in terms of what interventions we can provide now. So these trajectories are critical to determine how long and how well people live. And we know that if we intervene early stages, when there are things that can cause those downward steps on trajectories, that we can improve things. I think the key targets for intervention really are, about all the things we're talking today: exercise, education, and employment, and supporting schools and employers around that idea of getting people back, getting people at good levels of exercise, getting people back after surgery to their previous levels of exercise and so on, and also providing care that fits and considers those other aspects such as psychology needs. I think I already sort of alluded to it, but two very important tools when dealing with adults with congenital heart disease. One is to know the history and to not to get too bogged down into the detail, but to know generally, am I dealing with somebody who has a 2-ventricle heart that works in a similar way to somebody with acquired heart conditions, or is my patient you know, in that special group where they have either cyanotic congenital heart disease, where they have low saturations, which is standard for them, or with that Fontan circulation that just behaves in a slightly different way to the normal heart. And the telephone, because there are always people to advise, and that maybe the email as well as telephone, I should say now, because I think, you know, that's something that the network hopefully is bringing much more sort of making much more visible to people now about how we can actually, you know, even when they're just little questions, get the answers to those questions. So thank you. That's all I was going to talk about by way of an introduction, but I'm happy to take any questions.
Thank you. Perfect, thank you. So hi everyone, my name is Deepa, I'm one of the registrars at the Freeman Hospital. So I was hoping to talk to you this morning about cardiopulmonary exercise testing. What I was hoping to cover is, first of all, what is cardiopulmonary exercise testing, when we might request a test, and what are the contraindications for doing the test. I'll then talk about how we go on to interpret the results once we've got the data from the CPET test, what the clinical significance might be within cardiology, but also within other specialties, especially in congenital heart disease. Then I'll talk about a few limitations of the test, and then finish off with a couple of case examples. So cardiopulmonary exercise testing, essentially abbreviated as CPET, it's a non-invasive method that we use to assess the performance of both the heart and the lungs at rest and during exercise. And essentially, you know, why is it important that we learn about CPET? Well, more and more in the last few years, it's become a really important tool in not only cardiology, but also respiratory medicine, also sports medicine. So more and more, you know, it's a growing field, sports medicine, and CPET is being used to not only train competitive athletes, but also in rehabilitation medicine, where it can really help you, first of all, look at the baseline parameters of the person, of the patient, and then look at, you know, what kind of things you can do, what kind of exercise you can prescribe for that specific individual, depending on their, you know, comorbidities, depending on their level of fitness prior, and how you can prescribe a specific exercise program for them to be able to improve their exercise tolerance. And then you can use CPET again to check whether your intervention has helped them. So really useful in rehab medicine, sports medicine, and also more and more in pre-op anesthetic assessment. So I know over at the RVI, for example, they request quite a lot of CPETs within the surgical team. So for example, if you've got an elderly patient with comorbidities who might be frail, for example, who's got COPD, heart failure, and, you know, arthritis, for example, and you're trying to decide whether they're a candidate for open surgery versus keyhole surgery, CPET can give you information as to what their level of risk is in terms of, you know, intraoperative risk, post-operative risk, and really useful in this area. And I know down in Southampton, they have a big centre who are using CPET a lot in pre-op and kind of post-op assessment and rehab. The other thing to bear in mind is with advances in technology, CPET is now becoming more and more easier to administer, but also with the modern computer systems, interpretation of the results is also becoming easier as well. So I'm sorry to go through some physiology with you, but I thought it was quite important to just go through this very quickly to understand the physiology of exercise, so we can understand the interpretation of the CPET. But essentially, in order to perform a specific task, the body needs to provide the required energy. And this energy is primarily produced by breakdown of carbohydrates, protein, and also fat. But this is in the presence of oxygen. So in addition to fuel through food intake, the body also needs to provide the muscles with sufficient oxygen to have aerobic metabolism, essentially. And what happens is, as you exercise, the amount of oxygen and the rate of oxygen required increases as the intensity of exercise increases. And as with other burning processes, carbon dioxide is then produced. Now, this carbon dioxide gets transported back from the muscle cells to the lungs, where it is removed by respiration. So you can see from this diagram here in the alveoli, carbon dioxide comes out, deoxygenated blood is converted to oxygenated blood when oxygen is diffused in. But what happens is when you start exceeding a certain level of exercise, the body will not be able to provide sufficient oxygen to all of the exercising muscles. And then the additional required energy is produced by this anaerobic metabolism, essentially. And what happens is in anaerobic metabolism is in aerobic respiration, there's only a certain amount of oxygen initially that it's initially you get an abundance of oxygen, but then the more and more you exercise, you start to pant, you're trying to remove excess carbon dioxide, you're taking more oxygen, but it comes to a point where your energy reserves are being depleted, and then anaerobic respiration kicks in to try and provide this extra energy. And patient starts breathing heavily, and then they go into oxygen debt. And what happens is you get lactic acid buildup during anaerobic metabolism, and lactic acid is metabolized, it's buffered by bicarbonate, and then you get more production of carbon dioxide. And it's this increasing carbon dioxide that drives ventilation. So when someone's exercising, they breathe faster because they're trying to get rid of this excess carbon dioxide. And ultimately, there are a number of finely tuned physiological functions that need to fit and interact together, like a well-oiled machine, much like the impression of this gear wheel model, which was created by Wasserman. So Professor Wasserman was one of the pioneers of CPET initially. And essentially what he said is, for someone to be able to exercise effectively, you need to have a very good, interaction between, at the level of the mitochondria, at the level of the muscle, circulation, ventilation, and they all need to work together, for someone to be able to achieve their exercise capacity. And you can see from this diagram here how by measuring various parameters such as ventilation, oxygen, carbon dioxide, and heart rate, we can determine the overall capacity of the system, but we can also start to pinpoint where limitations might exist. So if someone has exercise intolerance, by measuring these various parameters, you can start to pinpoint where the problem might be. Is the problem at mitochondrial level? Is it muscle level? Is it a problem with the circulation or ventilation, or a mixture of these? So this is what CPET looks like. So the patient is on a bike ergometer, and they are connected to a number of different equipment. So they're connected to a blood pressure monitor, connected to a 12-lead ECG, an oxygen SAT probe, but also this face mask here, which can measure how much oxygen they're taking when they're exercising and how much carbon dioxide they're producing and how quickly they're breathing. And what happens at the beginning of the test, measurements are taken at rest, and then the bike ergometer starts to increase the workload on the bike. So it goes from 0 watts, 10 watts, 20 watts, for about 12 to 15 minutes. Most patients can manage up to more than 100 watts, depending on the fitness levels and the underlying diagnosis. But essentially, the patient starts cycling against this resistance, we keep going until as long as they can exercise for and at the maximum work rate that they can achieve. And while they're exercising, we can record things like oxygen, heart rate, respiratory rate, ECG tracing. We can measure how much oxygen they're consuming, how much carbon dioxide they're producing, among other things. And then once the patient kind of achieves their maximum exercise, then we stop the test, and then at the recovery phase, we continue to monitor all these parameters until recovery and make sure that the parameters go back to baseline again. Now, there's two types of exercise protocols that we used. The first one we used to use is incremental protocol, where essentially, the bike increases the power from 0, 10, 20, 30, like that. But more and more, the ramp protocol is being used, where the resistance increases gradually. So instead of going 0, 10, 20, it goes 0, 1, 2, 3, 4, and so on. And this is used more and more as it's more accurate to determine what the exercise capacity is. And previously, this is what we had as, the CPET used to be like this, but now there's more and more portable options. So In this diagram, you can see that a portable CPET machine is being used. So this is where the patient is kind of going up and down the corridor with the portable CPET machine, and the same parameters are being measured. So there's the ECG lead, there's the oxygen, there's a face mask that are measuring all the respiratory parameters. And the advantage of this is that CPET is now used a lot in other settings outside of hospitals. So for example, here on the left, you can see that this is a athlete essentially who is having a CPET done when they're running up a mountain. And then the picture on the right is quite interesting. So this was a study where they looked at different parameters on CPET at different altitudes on the Everest. So these people kind of were doing a study where they went at different altitudes and then look at what the oxygen consumption and the CO2 production is. So this is just to show you that it is becoming something that is more portable, and that with modern technology that it allows us to use it in different settings as well. So in terms of why we use CPET, I already mentioned preoperative assessment, but in congenital heart disease in particular, we use it to evaluate patients who might be, nearing heart, consideration for heart-lung transplantation. We use it for prognostic assessment and risk stratification. Very important in exercise intolerance and determining patients' exercise capacity, evaluating disease severity or progression. So for example, if someone has a significant lesion, but then, they tell you, well, they're asymptomatic, so you're trying to determine objectively from CPET, whether they are actually asymptomatic or whether they're just not pushing themselves enough to cause symptoms. So it can really give you, information as to whether, whether they might need intervention or whether they are truly asymptomatic and you can adopt a watchful wait approach for longer. I think more and more exercise prescription for rehabilitation, and also helps you determine whether the exercise intervention has made an impact. And I'll go on to show you a few examples of this. So there are a lot of studies that are being done recently looking at CPET-guided cardiac rehab on cardiopulmonary function. And this is a study from 2021 where they looked at CPET-guided rehabilitation in chronic heart failure patients. And it has been shown that, CPET-guided rehab not only helps increase heart and lung function, but also, reduces the NT-proBNP levels and high sensitivity troponin levels. And patients feel that the quality of life are improved more than when they compared it to, kind of a standard cardiac rehab that was not tailored to a specific patient's baseline parameters. And in congenital heart disease, CPET has a number of applications. So, this diagram just shows, for example, when we see a patient in clinic, we perform a history and physical examination, and we do a number of tests to try and, determine the current clinical status of the patient. So we might look at, the echo, what the ventricles look like on echo, what their pulmonary artery pressures might look like, whether they've got any evidence of arrhythmias on ECG, what the saturations are. However, these numbers, they are important, but I think from where cardiopulmonary exercise testing comes is, for example, if you're trying to determine if it's safe for someone to exercise, it helps you, first of all, reassure them that, we've done the CPET test and that, they were able to exercise for this much and for this long, and we haven't seen any particular significant arrhythmias or symptoms, then that helps you prescribe their exercise, for that particular patient. So it's used to plan the correct exercise intensity level. It can also help you assess the benefits of exercise prescription. And I think the third thing that's really important is if you have a patient who, you've suggested a period of cardiac rehabilitation for a few weeks, and then you've repeated the CPET test after that period, and they appear to be non or poor responders to the intervention, then it can help you identify those patients who perhaps need more advanced treatment or who are heading towards transplant because, the exercise program, for example, that the effect you expected hasn't shown that effect. So I think 3 different ways at least that CPET is useful in our population. So I'm just going to talk a little bit about interpretation of CPET. So this is Professor Wasserman who created the 9-panel plot, essentially that is used to interpret a CPET. Now, this is the 9-plot model, and at first glance, this may seem impossibly complex to to go through all the results, and all the full interpretation of a CPET requires expertise. I'd just like to show you that we can still perform a basic interpretation of it using a systematic approach. So when you look at panel 2, 3, and 5 here, so these are the cardiovascular panels. So you get the measurements relevant to the cardiac, essentially it points you towards any cardiac limitations. Panel 1, 4, and 7 are ventilation panels, so they help you identify whether the exercise intolerance is being caused by a respiratory problem. And then the rest of the panels, 6, 8, and 9, look at ventilation perfusion problems. But these are the data that you get, and I'll try to group them in 4 different categories. The first one is the work rate. So this is, how much in watts the patient was able to exercise, and how much we'll talk about that in more detail in a minute. The second thing is respiratory and gas exchange measurements. So when we talk about VO2, it's the amount of oxygen consumed by the patient when they're exercising. VCO2 means the carbon dioxide produced by the patient. Respiratory exchange ratio is the VCO2 divided by the VO2, and that's called the respiratory exchange ratio, or the RER. I'm not going to talk in detail about ventilatory measurements, but just to let you know that there are, a lot of measurements from a respiratory point of view, such as respiratory rate, saturations, minute ventilation, but these are all kind of parameters that help you determine whether there's a breathing problem that's causing their impairment rather than a cardiac problem. And then fourthly, you have lots of cardiovascular variables that you can look at, such as blood pressure, ECG changes, and heart rate. And this perioperative exercise testing and training society has provided recommendations on how we go on to interpret these tests. So I'm just going to go through it in a systematic fashion. So the first thing when you get a result is you want to make sure that the test is maximum in terms of effort. So really important, when someone's done a test, you want to make sure that they have reached the limits, the maximum potential, and they have reached the maximum effort and exercise, that they can. Because the problem is, if you get a suboptimal test, then all the values that you're getting may be an underestimate of what they can actually do. So when the patient says, they want to stop the test, we always ask, what made you stop? Is it that they had pain in their legs? Is it that they had any, chest pain, any ECG changes, any blood pressure problems that you're worried about? So really important to ask what made them stop the test. And then there are a few ways that you can, determine whether it was a maximum test. So first of all, when you put in the patient's height, weight, age, and sex, the CPET software automatically calculates how much, what the predicted maximum work rate is. And if they're able to achieve more than 80% of the predicted work, then that means it's a maximal test. And what it looks like on a graph on the panel is you can see this green line here is the stepwise, increase in work rates that that specific patient should achieve. And in this graph, you can see that all the parameters are increasing, in line with this work rate, and the patient was able to achieve their target heart rate. So this is a really good test. The second thing is you can look at the heart rate. So again, depending on the patient's age, they would have a predicted maximum heart rate. So that's usually calculated by 220 minus the age of the patient. So if the patient, achieves more than 80% of the predicted heart rate, then you can, reassure yourself that it is a maximal test. And this is what it looks like on the panel. So if you just focus on the grid here, so this is the calculated predicted maximum heart rate for this patient. And if you look at the burgundy points there, you can see that when the patient starts to exercise, the heart rate increases in a stepwise fashion. And this patient has managed to reach their target heart rate because, it's the dots are kind of in this grid here. So then, you can reassure yourself, yes, I've looked at the work rate, I've looked at the heart rate, and it looks like the patient has achieved what they're expected to achieve. Now, the third thing that's really important is looking at the respiratory exchange ratio. And if it's more than 1.15, then you can convince yourself that it is a maximum test. And just to recap what RER is, it's a really important concept when you look at a report. But essentially, it's the ratio between the amount of carbon dioxide produced and the amount of oxygen consumed. So if you think about it, at the beginning of exercise, you're consuming more oxygen than you're producing carbon dioxide. But as you start to exercise at a really high intensity and aerobic respiration has kicked in, Because more carbon dioxide is being produced than oxygen is being consumed, that ratio then changes. So the RER ratio starts becoming more than 1. And if someone has exercised up to their maximum level, then their RER should be more than 1.15 that we use to look at whether the effort was maximum. Now, once you've convinced yourself that it is a maximum test, there are a few numbers that you want to look at to see how fit the patient is. The first thing is the VO2 max. So VO2 is the amount of oxygen consumed during exercise, and each patient, the software will calculate what are their expected VO2 max. So what are their expected oxygen uptake at peak exercise. And the higher the VO2 max, it means the fitter the patient is. So in a graph form, you can see here the dotted red line, horizontal dotted red line is the predicted VO2 max for that patient. And you can see that this patient VO2 gradually increases as their work rate increases, and they have managed to achieve their VO2 max. So that's a really good result here. And the other concept is to understand is the anaerobic threshold. So this is the point where anaerobic respiration kicks in. And essentially, this when you plot VCO2 against VO2, initially when you're consuming more oxygen than you're producing carbon dioxide, you get a shallow line here, which is a red dotted line. But then at the point of where anaerobic respiration starts, because you're producing more CO2 than you're consuming VO2, you get a steep slope, and the intersection between these two slopes is what we call the anaerobic threshold. And this is a really important concept because patients whose anaerobic threshold happened at lower oxygen values, less than 11, have shown to be a higher risk of mortality after surgery compared to those who have a higher anaerobic threshold. Because if you think about it, if someone has a lower anaerobic threshold, it means that they enter anaerobic respiration earlier than someone who's got higher anaerobic threshold. So it means that that patient has a poorer outcome if they have surgery or if they become really unwell. So the higher the anaerobic threshold means the fitter the patient is. The fourth thing you want to look at is what the heart rate does in response to exercise. So normally the heart rate should increase rapidly, in response to exercise. But if a patient's heart rate response plateaus or starts reducing, then you're worried whether they've got any impairment in their cardiac output or whether they might be on medications such as beta blockers, or whether they might have chronotropic incompetence, for example. So this is what it looks like. So the heart rate should increase in parallel. But if you see any plateauing or decrease in your heart rate, then you would worry whether there's an impairment there. I'm not going to go through the respiratory parameters in detail, but essentially, as I mentioned before, there are things you can look at that points you towards whether the exercise impairment is being caused by obstructive or restrictive lung diseases. And CPET is used by our respiratory and pulmonary hypertension colleagues quite a lot for this patient population. Then the other important thing is the ECG changes. So, you would want to make sure that there is no, on exercise, there are no relevant ECG changes, such as ischemic changes, arrhythmias that might make you worry, about the exercise capacity of that patient. So I think just to summarize, there are quite a few numbers to look at in CPET, but I thought this table kind of gives you a good overview of interpretation. So, I think once you've made sure that the test is optimal, that the RER is more than 1.15, you look at the spirometry. If the spirometry is not normal and the patient is saturated in exercise, then it points to a primary lung disease. But if the spirometry is normal, then you can look at things like, anaerobic threshold and predicted VO2 max. And if these are abnormal and the patient is saturated in exercise, then you might suspect pulmonary hypertension. If they don't desaturate, then it points towards cardiac impairment. But if these are normal, if the VO2 and the predicted VO2 max is low, but then there's no evidence of desaturation, for example, then you would suspect whether the patient is deconditioned. So can really pinpoint towards where the problem is in that wheel that I showed you before. And these are just a few studies that have shown, particularly in cardiac conditions such as heart failure, they've looked at the parameters such as the VO2 max. And you can see here that the more severe the heart failure, the lower the VO2 max and the lower the anaerobic threshold. And this correlates with prognosis as well. So they looked at patients who had an aerobic threshold of less than 14 and more than 14, and the 2-year survival was, was almost half in those patients who had a lower anaerobic threshold, and the 2-year survival again was, was more than, was sort of 32% versus 84%. So it correlates with prognosis and mortality as well. And this shows the same thing, but essentially, they looked at the peak VO2 max in chronic heart failure patients, and those who had a VO2 of more than 21 had better survival rates than those with VO2 of less than 14, quite significantly there. In terms of, when we would worry about performing a CPET test, so it is absolutely contraindicated in patients with acute MIs and stable angina and stable arrhythmias, patients with acute infections such as endocarditis or severe symptomatic aortic stenosis, so acute heart failure. We would also not do them in patients who've got uncontrolled asthma, severe breathing difficulties, or if they've got significant psychiatric or cognitive impairment, which would limit cooperation on the bike. There are some relative contraindications, but essentially, if someone's got, for example, severe arterial hypertension, arrhythmias, high degree AV block, or advanced pregnancy, so we do use CPET quite a lot in pregnancy, because it's a good kind of measure of what happens, when you stress the body and what would happen to kind of plan the labor, for example. But I think it's more on a patient-to-patient basis to assess the risk of whether we think CPET is safe for them or not. So just to give you a couple of case examples. So this first example is someone who had cardiac rehab after a STEMI. The column here shows the parameters at 2 months after rehab, and then the one on the right is 8 months after rehab, and you can see that this patient had not only an increase in their predicted workload after a period of rehabilitation, so it went from 70% to 88%, but also their peak VO2 also was seen to increase, so from 64% predicted to 85% predicted. So and this was at a good respiratory exchange ratio of 1.14. So it was a good test. So it kind of gives you objective evidence that the rehabilitation program post STEMI has made an impact on their numbers, and I'm sure that would be reflected by by the patient's perceived quality of life improvement as well. Now, this is an example of someone with transposition of the great arteries, as Louise mentioned, where it's a burp defect, where the placement of the two arteries, the pulmonary artery and the aorta, are swapped around. And this patient had a mustard operation previously, where there was a baffle that redirects the blood from the right side to the left side of the heart and the left side to the right side of the heart. And when you do the CPET for this patient, you can immediately see that, first of all, the patient exercised for 11 minutes. And the dotted line at the top shows the predicted VO2 max, but this patient was not able to achieve the predicted VO2. It was much lower than expected. And essentially, this kind of gives you information at a starting point of what the baseline is. And then may perhaps help you, I think sometimes it's really important to look at the trend as well. So if you've done an intervention, repeat the CPET test, the intervention could be medications or surgery or rehab, for example, and then you can compare, how that would impact. So I think just some take-home messages. It is a relatively safe, non-invasive tool. It gives us excellent diagnostic and prognostic information in patients with heart disease. It is being used more and more in pre-op risk assessment as well as rehab. And it has, many advantages in exercise prescription because we're able to track different parameters such as VO2 max and aerobic threshold and so, rather than just heart rate. And I think the key limitations of CPET is mainly related to the expertise of those performing the test. So, all of the CPET tests need to be performed by experienced physiologists. Their equipment needs to be calibrated on a regular basis. They need to be familiar with troubleshooting the equipment. And I think this kind of is the main key limitation in providing the test at the moment. So I'm sorry this was quite a whistle-stop tour on CPET, but I just wondered if anyone had any comments.
Muirhead. I am an advanced clinical nurse specialist working within the Scottish Adult Congenital Cardiac Service, and we're based in a hospital called the Golden Jubilee Hospital, which is based just outside of Glasgow. So I am here to talk to you today about a feasibility study that we performed here in Glasgow, and it was looking at devising a structured exercise programme for our patient cohort. But before I begin and tell you a bit more about the study, I'd just like to give you some background as to why we got there in the first place. So this is Professor Hillis, Professor Stuart Hillis, OBE. And Professor Hillis was a cardiologist and was the first cardiologist in Scotland who probably recognised and identified the need for specialist ACHD care in Scotland, and he was fundamental for developing our service. He was also a professor of cardiovascular and exercise medicine at the University of Glasgow because his other passion in life was football. And Professor Hillis, having undertook a few team doctor roles, eventually became the team doctor for the Scottish national football team, which was a position he held for around about 40 years. Sadly, Professor Hillis passed away in 2014, but his family wanted to raise money and raise funds that they wanted to go to our service so that we could help improve care for adult congenital patients in Scotland. And so, of course, we wanted to develop a project that honoured Professor Hillis' interest, and so we had adult congenital heart disease and we had exercise. And what we wanted to do was develop an exercise programme for our patient cohort in Scotland that was simple, that was low intensity, low cost, and effective for all of our patients. And I say effective for all of our patients because, as I'm sure you know, historically, for some of our patients, there have been some barriers to exercise in the past. And many of you will remember having patients recalling being told to sit and draw a picture at school rather than participate in PE. We also know that exercise capacity varies widely across the spectrum of ACHD. So as I said, we wanted to develop a programme that was suitable and inclusive for all of our patients. And so we came up with this idea of a supported exercise programme for adults with congenital heart disease, also known as C-Change. So the lead on this project was our senior specialist physiotherapist at the Jubilee, Ms. Sheila Brown. It also involved myself, my colleague at the time, Jim Mearns, and we had support from our medical colleagues, Dr. Sam Rogers and Dr. Nikki Walker, who is also the clinical lead for our specialist service here in Glasgow. The aims of our project were fairly simple in that we wanted to introduce the supported exercise programme into clinical practice to support physical and psychological well-being. We measured through the attendance to the programme, including interaction with the online resource, which I'll talk to you about later, as well as attrition rate. And what we wanted to know is whether this supported exercise programme could improve exercise capacity. Could it improve respiratory muscle strength, which is something that we studied in one of our arms of the project? Could it improve muscle strength, grip strength, body composition, and psychological well-being? So the majority of our patients were recruited from the specialist ACHD clinic. And if I use my cursor, so this is Glasgow here. And it is fair to say that the majority of our patients who we recruited were from the central belt within Scotland, although we did have a few patients from the likes of Aberdeen, Inverness, and even further north than that. We also had some referrals from the medical examiner attached to the Live Active programme, which Glasgow City Council support. And this is a programme where local council gyms run specific classes that are aimed at people who have pre-existing medical conditions. And when she heard about our project, she asked, you know, if she had referrals, would it be okay if she referred to us almost as a stepping stone to give them a sort of baseline before moving into the Live Active type programme. And just briefly to mention as well, I think when you look at this map of Scotland, you can see why we have an appeal of providing a remote programme to our patients, particularly when we're thinking about all of our beautiful islands in the north and the west. Being able for patients to have remote access and not have to travel to Glasgow was a real bonus point for us. In terms of inclusion and exclusion criteria kind of speaks for itself. I guess the most important thing to say is that we didn't include our pulmonary hypertensive patients in this project, and that was mainly because our colleagues in the Scottish Pulmonary Vascular Unit were also doing a study at the same time and recruiting into that, so we didn't want to overlap. Equally, because it is a programme that was run remotely, it did need that our patients were comfortable using the internet, using email, using technology in order to access the online programme. And some other exclusions were, I guess, some of the patient cohorts where we worry about the most in terms of exercise, including like the outflow tract obstructions as well. So if we start kind of looking at our methodology, so when we had recruited our patients into the study, the first thing that we undertook was a 6-minute walk test. Now, all of you will, I'm sure, be aware that the 6-minute walk test is a very simple, very inexpensive and readily available tool. And once we had completed that, patients were then recruited into either group 1 if they walked less than 450 metres, or recruited into group 2 for those who walked greater than 450 metres. Why did we choose that number? Well, the literature does suggest that a walk distance of 482 metres or less correlates with a peak VO2 measured on CPET of less than 15.5 mils per kilogram per minute. And we know that that figure represents patients with significant cardiac impairment and increased likelihood of hospitalisation and adverse events. So that's why we chose that number. As well as a 6-minute walk test, we also did a number of other measurements, including height, weight, BMI. For those in group 1, we did this SNP test, or the sniff nasal inspiratory pressure, which again is a very short, inexpensive test that is used to assess inspiratory muscle strength, and thus gives us a very good idea of individual patient spirometry. We did quadricep and bicep strengths. We also included grip strength tests as well, because we know that grip strength is recognised as a method of assessing overall nutritional status, overall health status in subjects and patients who have medical conditions. And of course, importantly, we wanted to measure some psychological parameters as well. So we used the PHQ-9 and the GAD-7, which are both valid, reliable, self-reporting tools for depression and anxiety. And we felt that this was really important because we know that our patients with congenital heart disease have a higher incidence of psychological distress when compared to the general population. And we also know the benefits of exercise in helping to reduce psychological distress. For those patients who were recruited into group 1, they were supplied with a inspiratory muscle trainer, and this is a device which provides a set resistance to patients during inspiration. So they basically blow into a tube, and because of the resistance, this increases the workload of the diaphragm and the intercostal muscles, and over time can gradually lead to a strengthening effect. So we asked them to use the IMT twice a day, and they had a diary in which they were able to record, and by keeping in touch with us, we were able to incrementally increase the workload from that as well. As well as the IMT, we also recruited them onto their own personalised exercise programme. And the one that we used for this study was known or called Thalasso, which is an online exercise physio tool, if you like, which you're able to create a mixture of upper body, lower limb and core exercises, where you can individualise each programme and gradually increase the challenges over time to again obtain that gradual strengthening effect. Participants were able to record their sessions online, so we were able to measure their interaction, and it also allowed us to remotely monitor how they were getting on so that we could tweak their programs if required, and iron out any problems or issues that they had as well. So many of these exercises either use just your own body strength or the resistance bands, and of course we supplied our participants with those when they were recruited and at the time of initial assessment. For participants who were recruited into Group 2, as well as the online exercise programme, they also were given a walking programme, which was basically a step count chart. So what we asked patients to do was to give us an idea of what their daily step count was in the week preceding starting the 12-week study programme. And they recorded their steps using their own preferred method, so whether it was their mobile phone, whether it was their smartwatch. And as each of the individual participants were working to improve their own step goal and were not being compared with others, it meant that we didn't need to ensure that all participants were using the same device, which was an added bonus for us as well. So after the baseline number of steps were identified and established, then we would set a daily step goal for them. So for example, if they walked a baseline of 5,000 steps, then on week 1 we'd be asking them to walk 5,500, increasing to 6,500, 7,500 at weeks 3 and 5 respectively. Patients were asked to keep a diary and were logging their step goal every single day, and we used this 10% increase because we know again that the literature suggests that a weekly incremental increase of 10% offers an optimum level of benefit to the individual. So when we move on to look at some of our results, so in group, and I suppose I should say I haven't included all of the study demographics on this slide, but we had 10 participants recruited into Group 1 with an 80% completion rate, and equally in Group 2 we had 18 patients recruited with 15 completing, giving a completion rate of 83%. As you can see, the age range was wide, so we had a range between 18 years and 68 years was our oldest participant. Complexity of congenital heart disease was used in accordance with the 2020 ESC guideline, and we had a mixture of lesions including tetralogy of Fallot, systemic right ventricles and univentricular physiology as well. And also, as you can see here, many of our patients had had more than one sternotomy or thoracotomy in their lifetime. So this is the results for our 6-minute walk test. And what we can see is that in Group 1, 6 out of 8 of our patients improved in their 6-minute walk test during the 12-week study period. And this was an increase between 22 to 107 metres, with the mean 6-minute walk test distance at baseline being 377 metres, increasing to 409 metres at 12 weeks. In addition, the participants in Group 2, we saw an overall increase with 14 out of 15 of our participants recording a greater 6-minute walk test distance after the 12-week assessment. Their baseline mean was a distance of 494 metres, increasing to 526 metres. And what I should say at this time is that not all participants improved in every parameter for the duration of the study. However, every participant improved in at least one or more of the parameters during the study period. When we look at quadriceps strength, again, these box plots show that again we had an overall improvement. So in Group 1, all 8 participants improved in their quadriceps strength, and in Group 2, 13 out of the 15 participants improved. Equally with our bicep strength, we can see 6 out of 8 participants improved in group 1, their median at baseline being 106 newtons compared to 192 newtons at the 12 weeks. Equally in group 2, 14 out of 15 participants improved in their biceps strength, with the median at baseline being 208 newtons, increasing to 252 newtons at the 12 weeks. Similarly with grip strength, now these are combined data for both right and left hands, but again we can see 6 out of 8 of our participants in group 1 performed better at the 12-week review. Group 2, the results weren't as good, where only 9 out of the 15 participants improved on their grip strength. However, it is important to say that 73% of the group 2 participants had already achieved 100% or greater of the predicted norm at baseline. So really there wasn't that much room for them to improve. Now I won't go through all of the psychological parameters, but here are just some of them. So this is the anxiety score for group 1, and for those not familiar with the PHQ and GAD-7 scores, the lower the score, the better, if you like. And just to say as well, the data that is missing essentially means that the patient scored 0, so they had no levels of anxiety or depression. And again, we did see a bit of variation in the psychological measurements, not everybody improving, but overall the trend was an improvement in psychological well-being. One of the things that we maybe wish we'd done a little more of was that sort of qualitative aspect of the study, just to kind of find out a little bit more about people, what was going on in their lives and things. But most of them had said to us that if they had an increase in their GAD-7 or PHQ-9 score, it wasn't related to their heart or their health. It was related to external factors. And this is just the results for the PHQ-9 score for our group 2 participants. And as I said, overall, there was a general improvement, although perhaps not as convincing as the physical parameters. So we were very proud to have our study published in the International Journal of Cardiology and Congenital Heart Disease. What we found was that overall we did have a good rate of completion. The result was the study was most definitely inexpensive and didn't require much in terms of monetary resource. Being remote, it was readily available to all of our patients, regardless of where they live in Scotland. And importantly, we had no adverse events. For the participants who didn't complete the programme, it was mainly due to work commitments. I think we had somebody who developed a really bad cold, so wasn't able to participate for a week or two as well, but no adverse events. Some of the limitations of the study, well, yes, it was a purposive sample, in that you could argue that, you know, we recruited patients from the clinic who were more motivated to take part, and thus we were going to see an improvement in results. However, I guess this probably reflects real life in that those who are motivated to participate in everyday physical activity are the ones who will. You could argue that, you know, perhaps we saw improvements or such, you know, good adherence to the programme and improvement in results because we had that close contact and participants had that close contact with the study team. You know, we kept either in weekly contact or every second week, just to touch base with our participants. So we certainly kept that motivation, that encouragement alive. Technique. Yes, it is arguable that perhaps at the 12-week review, patients understood more how to use the myometers and things like that in order to measure strength. So perhaps that did affect results. And I suppose most importantly, it was a small study. You know, we did only have a small number of participants, so it wasn't powered to show statistical significance. But the data that we have achieved does suggest that there is a positive impact of a targeted exercise programme. And of course, reminding you that our aim of the study was to identify the feasibility of introducing a supported exercise programme like this into wider practice. And so our conclusions was that yes, most patients with CHD can safely engage in regular physical activity. Supported exercise programs can be safe, they can be effective. They do offer physical and psychological benefits, and low-cost measures with very little resource can often make a very big difference. So for us as a study team, what have we done since then? Well, the inspiratory muscle trainers we have continued to use in some of our higher risk patients, particularly in the prehab phase. So if we have a patient who's discussed at MDT and perhaps going for surgery, but we know that their lung function and spirometry is significantly reduced, then we have link them in with Sheila, our physiotherapist, so that we can get them using the IMT to build up that strength, you know, in that rehab period. And we certainly have a couple of cases that have been a real success in helping to reduce the ventilation time and get them through ICU as quickly as possible. Most definitely, the step count that we use is still in use, and this is a great way of helping patients to gradually build on their physical activity every day, and also sort of to monitor and see how they progress as well. The online exercise tool Salasso that we used, unfortunately, the cost attached to that has changed since the time of our study. So we are looking to identify a different online tool. There is one out there called Giraffe, which actually it was the Glasgow Caledonian University that have come up with. And again, this is a platform that delivers remote monitoring of personalised physiotherapy type programs for people with clinical conditions. So we're just looking to get that set up for our patients. And I think it is important to identify that, you know, we still work closely with Sheila, but she has no dedicated time to spend with our adult congenital patients. And we're working really hard and would love for her to have some time secured and ring fenced so that she can help just get as many patients as we can onto a supported exercise programme as we can. And finally, I would just like to offer thanks to my colleagues in the study team. I have to say it's one of the most enjoyable things that I've done over the last few years. You know, it was fantastic seeing these patients through and supporting them through, you know, and seeing the results at the end. I'd like to thank Professor Hillis Adult Congenital Fund, because without that very kind donation, we would never have been able to run this project. And also to the Golden Jubilee, who sponsored our project as well. So I think that is all from me. As I said, I am so sorry that I wasn't able to be there in person or with you live. If you do have any questions, please either just hand them to Kay, and Kay can send them all to me in a oneer, or happy for you to email me. I've put my address on the screen there, but I hope you have a really enjoyable rest of the morning, and hopefully see some of you in the very near future. Thank you.
Okay, Caroline, I'll just go on mute and just give me the nod when you need me to move.
Cool, thank you very much, Kay. So yeah, thank you very much for inviting me along. It's a huge privilege to be here today, and it's great hearing different speakers talk, because rather than our own network and people down in the southwest. So thank you very much for having me along. So I'm Caroline Evans, and I'm a cardiac specialist physiotherapist. I'm not attached to the ACHD team, but I do spend quite a lot of time, and that is where my specialist interest lies. And I feel very fortunate to come to different events and learn from everybody. So thank you. So today I'm going to be talking to you about ACHD, prehab and rehab, and different considerations for prescribing exercise to this cohort of patients. Next slide, please. So what are the health benefits for physical activity? The benefits are huge, and you often hear you should exercise as if your life depends on it, and it's pretty much true. Depend rather if you're a child, an adult, or even an older population, that has benefits from everyone. It's going to help prevent cancer, depression, your cognitive function, improve your sleep, improve your weight status, decrease your falls. It is absolutely huge. And for our congenital patients, it also gives the patients some control over their health. So it gives them some control in an uncertain world, and it's something that the patients can do to help themselves. So it's really important that we're able to give them the knowledge and the expertise and the empowerment to go away and do exercise. Next slide, please. So how much physical activity should we be doing? Well, the guidelines show that we should be aiming for 150 minutes of moderate intensity exercise or 75 minutes of vigorous exercise a week. And we should also include strength training twice a week, minimize sedentary time, and also do balance work for the older population as well, twice a week. But research has shown that 4 out of 10 men and 3 out of 10 women in the UK meet the guidelines. So that's a incredible amount of people that are not meeting the guidelines. And the congenital heart patients are known to be predominantly sedentary, have a reduced exercise capacity, and are obese compared to their peers. But being sedentary actually doubles your risk of serious disease, and it leads to a premature death. So it's important that we get these patients exercising as well. But when we're thinking about the guidelines, we shouldn't be aiming for those guidelines straight away. If you're going from the couch to aiming for those guidelines, they're going to get demotivated, they're going to get achy, they're going to get tired, they're just not going to do it because it's going to be too hard. So what we should be looking at is how much exercise the patients are doing to begin with, and then increasing by 10% each week. So it's either a 10% increase in time or a 10% increase in distance, but gradually build up. We always say, have your goals so small you cannot fail, and then build up from there. Next slide, please. So that was for the adult population. So we're going to ignore the 1s and 5s and unders, but for the adolescents, they should be looking at 60 minutes every day of exercise, and also the importance is sitting less and moving more. So sitting is now known as the new smoking, and we just want to break up that sedentary time. So with a lot of the watches these days will give you a buzz to stand up every hour or so. That's because of this. So sit less, move more. Next slide, please. So what's the difference between physical activity and exercise? Physical activity is bodily movement produced by skeletal muscles that requires energy expenditure. So housework, gardening, climbing stairs, etc. So all of physical activity does have benefits as well as exercise. Whereas exercise, on the other hand, is planned, structured, purposeful activity pursued for health and fitness benefits. So time has to be set aside. So example, running, swimming, cycling, football, etc. But is exercise safe? Well, we've heard several people say today that yes, exercise is safe for the congenital heart patients. Sudden cardiac death is very rare in the congenital heart population, with less than 0.1% per year, and so that's 8% of those deaths are during exercise. But that the most commonly sudden cardiac death is associated with the undiagnosed congenital heart disease patients, not those that are known to us. Next slide, please. So when we're thinking about exercise prescription, we use the FIT principle to prescribe our exercise. So that stands for frequency, intensity, time, and type. So frequency relates to how often you want them to exercise. So there's no difference between longer and fewer sessions compared to shorter and more frequent ones. It's the overall time that counts. Intensity is the magnitude of effort that you want the patient to put in, so it could be light, moderate or high intensity, and the intensity is the important part. The higher the intensity, the better the outcomes of the physiological changes to the exercise, but it needs to be appropriate intensity according to the patient's anatomy and physiology, so it needs to be safe, and we'll talk about that shortly. Time is what it says on the tin, and it relates to the single session or overall training, whether it's been years or months. And we know that every 10 minutes counts. So it could be 10 minutes 3 times a day to get to your 30 minutes. And we can trade frequency and time. So it's the overall duration of the exercise. Type refers to the aerobic, the type of exercise, so it's whether it's aerobic, resistance, dynamic, static, and they're all a bit different, and we'll talk about that slightly later. The main thing that we need to think about is, hang on, can you go back one? Thank you. The main thing that we need to think about is progressive overload, so that we don't want the patients to just stay at doing the same exercise all the time, because they're not going to get fitter, they're going to maintain their fitness. So by progressive overload, we need to make it harder. So it's generally, we say the 10% rule. So we either increase the weight by 10%, increase your time by 10%, or increase your frequency by 10%. We don't do it all at once. So using the FIT principle, we would first of all, next slide, increase the time that you spent with the exercise. Next slide. Then you'd increase the frequency. Next one. Thank you. Then you would increase the intensity. Next one. But remember, the intensity, although it's last, it's the most important, but it needs to be appropriate according to that patient. Next slide, please. So when we're talking about intensity of exercise, there's different ways that we can determine the intensity that the patients work at. So metabolic equivalent is the amount of oxygen consumed during exercise, and it can be split into light, moderate and vigorous. So 3 or less is METs is light intensity, 3 to 6 is moderate, and 6 or above is high or vigorous intensity. But the fitter you are, the less METs you use. So this is a pretty rough guide. And what we can do is ask the patient questions, find out what kind of MET scores they're doing on a day-to-day basis, and then we can use a table to show what levels of METs that they can do comfortably, and I'll go through that in shortly. But just to reassure you that most exercise-induced arrhythmias occur at 9.5 METs, which is a huge, like massive intensity, really vigorous, and it's way higher than the majority of our patients will work. So that should put your mind at ease somewhat. Next slide, please. So the Duke Activity Status Index is a way of working out patients' METs, and there is a free MedCalc, which is an app that we use a lot to calculate patients' MET score. So they will just fill out the questionnaire, and it will add it all up as to, do you feel, can you walk indoors? Yes, no, and then it'll give you the MET scores, and then it will tell you what activities are appropriate for them, or what's going to push them too high in their MET scores. And you can print that out and pop it in the notes. So we use that with all our cardiac rehab patients, which is a really useful tool. Next slide, please. The other thing that we use is the perceived exertion scales. So these are the Borg scales. So I've got 2 different scales here. The CR10 scale is 0 to 10, and the Borg scale is 7 to 20. And this is a scale that determines how the patient is actually feeling when they're exercising. So how breathless they are, how the muscles are feeling, do they feel able to continue, how hard they're actually working. And it took me ages to work out, like, why is it 7 to 20? Why not just like the CR10 score? Why is it not 0 to 10? But the 7 to 20 actually relates to your heart rate. So if you score like a 13, if you times it by 10, that should be a rough guide as to what your heart rate's doing. And you'll find a lot of the majority of the cardiac documentation with like the British Heart Foundation and whatnot tend to use the Borg scale rather than the CR10 score because of that. And the other good thing about these scales is it helps to normalize exercise. So I quite often get my patients will be saying, I'm really short of breath and my heart rate's going 10 to the dozen and I'm just not, this isn't right, this isn't, and it's like, oh, I'm glad that's happening because that happens when I exercise as well. You should be getting breathless, your heart rate should be going up. It is completely normal. So we want them to be exercising between 12 and 16 on the Borg scale. So out of breath but able to talk. Next slide, please. The other thing that we use is training heart rate zones, and the Canorvan formula is the one that we use mainly because it uses your heart rate reserve and goes on your resting heart rate and your medication as well. So it's a bit of a long-winded calculation and it works out your training heart rate zone to 40 to 70% of your heart rate reserve, and it's been shown that to get a sufficient exercise load to increase your aerobic performance, that we should be exercising between 50 and 80% of your heart rate reserve. So it's a rough guide for patients. It's not appropriate for children or post-heart transplant, so we would be using the Borg scale more so for those patients. And we use a 30 to 50% heart rate reserve for very deconditioned patients and the Keating regression equation for heart failure patients. Athletes would laugh in your face at these. They'd be like, that is not a good training range for us, and they would be working a lot harder. And with patients who have had ICDs, then it is recommended that they exercise at 10 beats below their threshold. And the guidelines suggest that patients with ICDs are the group that use heart rate monitors to monitor their heart rates until they are used to the Borg scales and know how hard they should be working, and not to push themselves over that threshold. Next slide, please. So there's different ways of classifying exercises according to for cardiac patients, and this is the Mitchell classification of sports, and this is an old school one, and it's out of date, but it's quite good to talk through anyway. So the different colours relate to the volume, load, and the afterload pressures on the heart and how hard the heart is actually having to work. So the green, the heart isn't working that hard, and the red, it's like, yeah, full on. But the exercises in this classification aren't necessarily in the right places, so we know that it's an American one, and they don't play cricket, so they put it in the green, whereas it should be more likely up in the red. It's a lot harder going. So along the bottom, we've got increasing dynamic component, and with the increasing dynamic component of exercise, you're going to get an increasing of volume load on the heart, whereas on the going up the side, we've got increasing static component, and that means we have got an increase afterload on the heart, so the heart's having to work a lot harder. Next slide, please. But there's also lots of different things that we need to consider when we're prescribing exercises. So which part of the body are we exercising? Is it the upper limbs or the lower limbs? You might be thinking, why is that important? Our surface area in our upper limbs is a lot smaller than our lower limbs. So if we start doing a load of upper limb exercises, your blood is going to rush to your arms in that small surface area and really drive up your afterload, and your blood pressure is going to shoot up and make your heart have to work a lot harder.
So it's important that if we are doing upper limb exercises, we want to do a mixture of upper limb and lower limb, or just keep those feet moving at the same time, just to prevent the afterload from happening. We've got to think about the position that they're exercising in, because your position is going to affect your venous return. And also quick positional changes has been shown to increase your interthoracic pressure, which is going to increase your risk of arrhythmias. Also, we need to think about what type of sports are they playing? Are they playing contact sports? Do they have any devices that is going to at risk of getting battered during the sports, or do they need to wear protection, or is that sport not appropriate for them at all? Also, what's the risk of those patients if they do have a syncope? Are they going to be riding a horse or going down a black ski run? And if they black out, are they going to wipe out a load of people and cause injury to other people as well as themselves? It's lots of things to think about. Medications, whether they are on warfarin and their risk of injury, risk of bruising and bleeding. Also, what level of competition? Is it a little knockaround that they're playing, or is it to an elite level? So if the patient feels unwell, are they able to leave the sport, or is it the be all and end all that they must charge around and get that ball and they're not going to limit themselves? These are all really important discussions to have. Also, what position on the team do they play? Are they playing somewhere that they have to run around a lot, or are they able to take a step back a little bit? Thinking about the sudden acceleration and deceleration, because with those you're going to get a huge rush of an adrenaline, and then all of a sudden if you've got a deceleration, you're still going to have that flush of adrenaline, which is going to put you at risk of arrhythmias. Thinking about techniques and environment as well. So weightlifters and swimmers are going to be doing breath holding or valsalva removers, and that's going to increase their interthoracic pressure, which is going to result in bradycardias, and it's going to increase your peripheral resistance as well. So it's huge amounts of things to think about. Next slide, please. So it's been made a lot easier for us by this new table that's come out. So it's split exercises and sports into skills, power, mixed and endurance, and it tells us the effect that it has on heart rate, blood pressure, cardiac output, volume training and cardiac remodeling, and it has the list of exercises at the bottom as well. So it's made it a lot easier. Next slide, please. So this is an assessment tool as to how you can use the last slide. So during the assessment of the patient, you'll be looking at the ventricles and whether there's systolic dysfunction or hypertrophy, and then pulmonary artery pressures, and the aorta, and if there's any dilatation or not, arrhythmias, do they exist, and how significant is the burden, and what the saturations are at rest and during exercise. And then depending on how that assessment goes, it will tell you, going back to the other slide, which kind of exercise that is appropriate for those patients. So it's been made a lot easier. Next slide, please. So there's different types of exercise that we can do with our patients, and high intensity interval training is very popular at the moment, and it compared to moderate exercise, it's been shown to increase your aerobic fitness, muscle tone, insulin sensitivity, fat burning, and increase the mitochondrial number and efficiency. So it's much better for us compared, you're going to get like better results compared to steady rate exercise, but although the guidelines and research are showing that it might be okay for patients with congenital heart disease and cardiovascular disease, the guidelines aren't there yet. So we still do not advise our patients to do high intensity interval training unless they are being monitored and being supervised. And let's face it, that's none of our patients. So although the tide is trying to change on this, we're not quite there yet. So we'll stay away from it at the moment. Next slide, please. Yeah, so that was just gone over what I've said. Next slide. So we'll go for interval training instead. So interval training is periods of high intensity effort mixed in with low intensity effort. So if you think about the couch to 5K, it'll be run, walk, run, walk, run, walk. And then over time, you build up the time that you're actually running for and decrease the amount of time that you're walking for. And it's recommended for patients with heart failure and also very deconditioned and compromised individuals, and it's considered more effective than continuous exercise for increasing exercise tolerance. So yeah, no, it's a good one to go for. Next one, please. Inspiratory muscle training. So we heard a bit about this earlier. So it is a handheld device that trains your inspiratory muscles, and you can increase the resistance that you're using to breathe in against. So it's quick and easy to use. It's been shown to be useful for patients with Fontans and heart failure, and it's got promising results in ACHD. It improves the exercise capacity and quality of life of patients, and it's available on prescription. However, it needs to be taught. It can't just be prescribed and then not go through, because it's easy if you know how to use it, but if you're trying to just wing it, the likelihood is you'll be training the wrong muscles. So it is important that you train the person that will be using it. Next slide, please. So resistance training tends to get forgotten about, but it is incredibly important that we aren't just advocating cardiovascular exercise, but we're actually working with the patients to build up resistance training as well. Next one, please. And this is because it helps improve bone formation, muscle strength, and power, improves your cholesterol, glucose metabolism, and increases your muscle pump, and it reduces bone loss, blood pressure, and helps maintain weight. Next one. So if we look at weight trainers in general, or competitors lifters, they hyperventilate prior to lifting, they squat, and they will Valsalva, which is going to massively increase their afterload and decrease their venous return, which is not something we want to do. And they also go for a really high rep max, so they'll go for an 85% of their maximum lift that they can do, and do reps of that, which is not something that we want to do because it's going to put too much strain on the heart. Next one. So what we do want is to work selected muscle groups to fatigue, aiming for 8 to 10 reps for strength and power, 15 to 20 for endurance, aiming for 2 to 4 sets twice a week, but no more than 4 times a week. Avoid breath holding and isometric exercises, and it doesn't need to be like weights training. I couldn't think of anything worse, to be honest. It can be yoga, swimming, and it can be simple exercises like heel raises whilst they're waiting for the kettle to do, or lunges whilst they're waiting for the toaster, or exercises when they're in the queue for the bus stops. Everybody thinks, oh God, how am I going to fit in this exercise into my busy schedule? You can break it down really simply, and it's going to make a difference. Next slide, please. So what's the right amount of exercise? We know what the guidelines say we should be doing, but in all honesty, how many people are doing the guidelines, let alone how many congenital heart patients are? So it's good to know that even if we're just doing less than that, we're still going to get benefits. So 60 minutes of brisk walking a week decreases your risk of coronary heart disease by between 20 to 50%. So that's quite a big quick win, really. Running 5 to 10 minutes per day, or less than 60 minutes per week, decreases your risk also by 50%, and a single bout of high intensity exercise also decreases your risk by 50%. And the main thing is that we sit less and move more. So we know that even if you do loads of exercise, it won't make up for doing an hour's worth of exercise a day and then you spend the rest of your day sitting still. You need to still sit less, move more. Next slide, please. So there's different apps that we can use to get patients to become more active. And these are both government incentive ones, and they're free. So the Active 10 encourages patients, well, people to walk around at moderate brisk walk in bouts of 10 minutes throughout the day. So on the side, you'll see that it'll have yellow bars where the patient's plodding along, and then when they hit the moderate intensity walking pace, then they'll get to the green one. And what they'll do, it'll send you alerts and be like, hey, Eleanor, well done, you've hit your 10. And then once you've hit your 10, it'll then go on to aim for 2 lots of 10 and 3 lots of 10. So then you're hitting your 30 minutes of moderate intensity exercise. But it's not going to be appropriate for all patients. So poor Eleanor here has just had a, hey, Eleanor, pick up your pace. But poor Eleanor might have heart failure, and she might be working her hardest, but not ever going to be able to hit that moderate pace. So it's going to be very individualized. And I'll talk about another app that we can use for patients that are going to find it a bit more challenging. The other one we can use is the Couch to 5K, which gets you from the couch to running 5K over a 6-week period, and just goes at a gentle pace. And again, we should be looking at increasing the walking distance by 10% each week. Next slide, please. So the other apps that I would use for the patients if they do have heart failure or are incredibly deconditioned and are going to find it tricky to get to the 10 minutes of moderate walking would be Pacer. So it's a bit like Strava for anybody who uses Strava. So it's like a social media outlet for exercise, where you can get likes and share your progress, and it gives you feedback as to how hard you're training and the distance that you're doing and the intensity, and it also works out how many calories you've used as well. And the Pacer is for sedentary patients or people in general. Strava is like Pacer, but for people who tend to, it tracks your walking, running, cycling, canoeing, whatever, you name it, it'll track your distance and tell you how hard you've worked compared to other times, and you can befriend people and like and comment on how well people are doing. So different things motivate different people. Also like like a walking tracker or a Fitbit, but it's just all very much a personal preference. Next slide, please. So we've talked about exercise prescription, but we need to think about this as prehab as well as rehab. So we know CHD patients are living longer, and the need and risk of procedures and length of stay and recovery time is really important for the prehab. The sooner they get better, the better it's going to be for everybody, and anything is better than nothing. But we need to be thinking about a holistic approach. We need to be thinking about the lifestyle advice, so decreasing the amount of alcohol, smoking, dietary, stress management, and medically optimize these patients. It's not just about exercise. We need to be thinking Sky Sports and go for a whole holistic view for the patient. Next slide, please. So rehab, although that will start straight away after the operation or procedure that they're having, with education and discussion with patients, what their expectations are going to be and what they need to be doing, and it starts beforehand. But it's everybody's responsibility to get the patient sitting out, making sure that their patients are dressed in their own clothes, mobilising out to the toilet rather than using commodes, making sure that they've got drip stands to mobilise independently, and ensure pain is well controlled as well. Next slide, please. So benefits of exercise are huge, as we've discussed earlier, but it's a bit unfortunate that we get this thing called deconditioning or detraining. So the benefits of exercise are actually reversed within 2 weeks of stopping exercise. So that isn't very long at all. And if we're thinking about the effects of lockdown and shielding, where people weren't leaving their houses and moving around as much, that's had a massive knock-on effect of physical health. And we also need to think about if the patients are going into hospital for any procedures or going on holiday, is much better and easier for them to continue to exercise rather than stop, start, stop, start. But obviously it's not always appropriate. Some people do need to have time out from exercise. And if that's the case, then you need to start a bit slower and then build back up. And the good thing is, after long-term training, so 9 months or more, deconditioning is more gradual and takes place over months rather than weeks. So we can all sigh a bit of relief there. Next slide, please. So barriers to exercise, everybody has them. This was taken from a paper on barriers to exercise for heart failure patients. I think the mean age was 50, so a bit older than some of our patient cohort, but the barriers are pretty much the same. So we'll look through them and we'll talk through some of them. So suffering from minor injuries, we can go through stretches and warm-ups to decrease the risk of injuries. Need time to spend on other things. We need to think about priorities for patients, and exercise really should be a priority because it's going to give them control over their health, and it's going to have increase their morbidity and improve their morbidity and mortality. So it's really, really important. Need to spend time with a family. They can exercise and do things with their family. It could actually help bring them everybody together. Feeling physically tired, well, exercise is going to help increase their endurance so that they should feel less tired. Experience symptoms, so think about your assessments and what symptoms are they experiencing. Is it that dreaded breathlessness and increase in heart rate that everybody complains about with exercise, or is it something different? We need to break that down. Or are they exercising at a completely inappropriate level? Working long hours, so look at what they could do within work, so getting standing desks or walking to different floors to get water or the toilet. Look at their commute. Can they cycle or walk to work? Feeling bored of exercise, get them to listen to music or exercise with friends. Experience the side effects of medication, well, exercise will hopefully help them decrease some of the medication that they're on. Weather is bad, exercise inside. Hard to get to the gym. Actually, don't call it a gym. It's been shown that if we call it a leisure centre rather than a gym, more people are more likely to go to a leisure centre than they are a gym, which is quite amusing. But it doesn't need to be a gym. You can exercise at home. It can be free. And exercise doesn't need to be expensive at all. Families not interested in exercise, well, we quite often look at what the family is interested in. So we've had people that are interested in photography, so they'll go for a walk with their cameras, or if they're interested in watching Coronation Street, can they use that Coronation Street as a, or whatever TV program is, as a reminder to exercise? So sit on an exercise bike and pedal their way through it, and then they'll exercise regularly. Or afraid of getting hurt through exercise. Again, just warm up and cool down and make sure that they're exercising at the appropriate level. So research has shown us that congenital heart patients are willing to exercise, but they're uncertain of the safety and type. So it's just important for us to educate them. Next slide, please. So motivation, so we should be using motivational interviewing. What's important to your patient, educating them as to do's and don'ts, and the importance of what the health benefits of their exercises. Help them set goals. Patients don't really know what they can achieve through exercise, let alone how to go about it. So it's important that we help them with those. Get them to share their goals and success with others, and help them to celebrate their success. Get them to reward themselves, but make sure that the reward is appropriate. So we know that 40% of people who start off with exercise programs actually put on weight, and they come to you and like, yeah, put on muscle, or put on some weight. And it's just like, you've just been walking around the block. Well, that's not quite happened yet. And what research has found that people starting out will increase their calorie intake, or they'll go for a walk and then reward themselves with a big dot of cake afterwards. But you don't actually need to increase your calorie intake unless you're doing endurance training. So it's just making them aware of that. You don't want to trade with increasing physical activity with increasing obesity. Make it fun and get them to exercise with others. Make it habitual exercise, so can they go and use exercise to commute and have their visual cue. So rather than using the exercise bike as a clothes horse, making sure that they can see it and the trainers are out by the door ready to go. And exercising in green spaces is great for mental well-being as well. And also get the advice on what they can do rather than focusing on what they can't do. Next slide, please. So encouraging children. So I know we're talking about adolescents and adults here, but it's important that we encourage them from when they're children, because if you start them in really good habits when they're young, that will hopefully continue throughout their lifestyle. So next slide. So this is my daughter doing her first park run, and as you can see, although her t-shirt says happy, she really wasn't very happy about it at all. Next slide, please. So we tried cycling, and that was about as dismal as a park run. And next slide, please. But over time, next slide, she has grown to love exercise. And you think, like being a physio and somebody who loves exercise myself, that my daughter would just follow suit, but it's not been the case. We've had to work pretty hard on this one. So next slide. So the things that we have done is making sure that we're doing developmentally appropriate exercises for the children and not pushing them too hard or too soon, making sure that they have the appropriate clothing and active toys so that they feel comfortable when they're doing it. Be a role model, so encouraging their parents and their family and their friends to exercise as well, and then they'll join in. Encourage family members to play with them, decrease the screen time, praise and reward them, make time to do it. So a lot of children have really busy schedules and go to lots of different clubs. So it's making sure that they have time to do it. Don't overdo it. So start small and then build up. Decrease the competition so that everybody's got a sense of achievement, and get pets like dogs. It's not talking about goldfish here. Dogs to take out on walks, and get them to join teams and involve the child. What does the child want to do? What teams do they want to try out for? Persevere and make it fun. So as we know, not everybody's going to start off really skilled at a sport or an exercise. It takes time and practice. And if you swap and change a child's schedule so much really quickly that they're not actually going to get time to become skilled at that exercise, and that's going to help improve their self-esteem when they get better at something. So don't swap and change too much. And next slide, please. And then we know that bad childhood experiences with exercise turns into sedentary adults, so it's really important that we keep it fun. Next slide. So this is a patient, the picture of my daughter's rather, visiting me on CCU. So I'm not a congenital heart patient, but I am a cardiology patient. So I have got a history of numerous emergency admissions for VT with syncope, and I've had numerous 5 or so ablations, and I don't have an ICD, but exercise is a huge part of my life. So I became a physio, and I still very much run. Next slide, please. But this was very much the look of everybody after I've had all my ablations, and I was getting back out running, back to the gym. The look of horror from my my friends, my colleagues, my family. It was just, what are you doing? And if I didn't have the mindset that I do, I wouldn't be exercising now. And it is so important that we give our patients the confidence and the knowledge to go out and exercise, because by empowering our patients to exercise, you will make the biggest difference to their life. And I'm so grateful that I am still able to exercise and I still do it, because my life would be very, very different, and so would my child's. And that makes me really, really sad. So do please empower your patients to exercise. You'll make the biggest difference to them. We also need to think about the risk adverse, so the risk takers versus the risk adverse. So some patients you'll have to pull back a little bit, and other ones you'll need to shimmy along to try and get them back to exercise, and refer to the psychology if needed. Next slide, please. So it's really important that we know that refraining from exercise, it's not always going to be appropriate for patients to exercise, and that is absolutely fine. But we're not talking about guidelines here. We are talking about people and what their psychological impact is. And the psychological impact on patients who exercise all the time, and it's a massive part of their life, if they're told to stop exercising, that is huge. It's not a guideline, it's that it's huge. And it only takes 2 days to become clinically depressed if once you've stopped exercising. So it's something that we really need to handle carefully with these patients. And evidence shows that 6% of patients felt that exercise restrictions has a negative impact on their mental health. And the guidelines suggest that we should wean off exercise if safe to do so, rather than just stopping suddenly. But I think that really depends on the individual, because if that was me, I would want to go out with bang, I'd want to go out for PB, which would be completely inappropriate. I know the safety and all the rest of it, but that's what I would want to be doing. So have those discussions with those patients, and think about other ways that the patients can be involved in their sports. So can they be going into refereeing, marshalling, or coaching? Next slide, please. So other things to think about from the safety considerations. So when I had one of my syncopal episodes, I was in the gym on the way into a yoga, and yoga session, and I came round and they were just like, don't cancel the ambulance, she's okay. And I was just like, I'm not okay, and go and get an ICD, please, and like your defib, please. And it dawned on me that they didn't know anything about me, although you fill out your form, they don't know who it is lying on the floor. And yeah, so I now have trainer tabs on each of my shoes that has your ID on it, and a little bit of blurb and your next of kin and stuff, and might not be the first place to look, but it helps give me reassurance that they'll get there eventually. Strava has an bit on the app where you can get an alert sent to somebody so that they can track you when you're out running. So if you're not well, then they can press it or notify them if you stop. Your smartwatches have fall recognitions that can phone your next of kin or an ambulance if you have a fall. You find your friends. So there's different things that people can use to help build up their confidence and for their own safety as well. Also for the patients who have GTN sprays, for them to carry those, and to exercise in places where they've got defibs as well. So other things to think about from a safety perspective is making sure that we assess the patients and give out individualised exercise prescriptions. So it's not a one size fits all, it's very individualised according to the patients. Educate the patients on what they can and can't do. Think about the levels of supervision and assistance in the environment. So are they a keen swimmer? Are they going to a private hotel with no lifeguard and no defib, or is there a lifeguard on duty? So thinking about the extremes of temperature, because that's going to have a knock-on effect of your afterload and preload, and your hydration. recognizing signs and symptoms of overexertion and not to when it's not appropriate to exercise, asking them to avoid breath holding and Valsalva, making sure that they understand the management of chest pain and severe breathlessness and what they should do. Ensure that they have adequate warm-ups and cool down, so that's going to decrease the risk of arrhythmias and increase your ischemic thresholds. So we should be aiming for a 15-minute warm-up and a 10-minute cool down, and it should be slightly shorter for heart failure patients and slightly longer for heart transplant patients. Next slide, please. So key messages. Make sure you include a warm-up and cool down. Every 10 minutes counts. Intensity is the most important part of your FIT principle, but it needs to be appropriate. Make sure your exercise prescription is individualized according to the anatomy and physiology, the medication and what devices the patients have, but also the psychology of the patients as well. Think about the type of exercise and don't forget about the strengthening work. And education with the patients for the do's and don'ts of exercise and how to monitor themselves. But most importantly, please empower your patients to exercise. You will make the biggest difference to their lives. Next slide. And then we just got some resources here. Next slide, please. And the guidelines are here. Next slide. And we're done.
It's Mark Overton. I'm a congenital heart patient. I represent patients on the Northeast North Cumbria Congenital Heart Network. In a previous life before I retired, was actually a consultant specialist in public health. So I've come from a background of being interested in this kind of thing anyway. And my old director of public health, Nonnie Crawford, used to say, when you've met one GP, remember you've only met one GP, because everybody's different. And I've used this as the title because it's a plea to remember that we're all different. And I'm sure everybody who's involved will think that, but it's just when you've met one congenital patient, remember you've met one congenital heart patient. We all are different. We've all had a different life course. We all have a whole range of barriers in our lives which will prevent us from just happily slipping on the Ligra and getting involved in running 5K. That will be beyond the wit of some of the people that when I sit in clinic day at the Freeman and I look next door to me and I think, crikey, they could as much run 5K. It's just not within their capacity to understand. Could you put it to the next slide for me, please, Kay? Sorry, I'm getting a bit Professor Whitty here. Next slide, please, Kay.
It's moved on mine, Mark. Is it not yours?
All right. Okay, it hasn't moved on my. No, it hasn't.
Has it moved on anybody else's? No.
No, it's still stuck. I think you need to enable editing, Kay, before you then do a slideshow.
I thought that as soon as I did it. Okay. Apologies, Mark. Sack the team. Let's try again. How's that?
That's what. Okay, thank you.
Perfect.
Right, just this would be obviously be my mastermind specialist subject, which would be me, obviously, and it's my patient life course. So that's about I was in 1963. I'm 63 years old now. 1963, a vigilant GP recognised there was something wasn't quite right. Identified as a defective aortal valve at the aortic stenosis at the RVI. Went right through that and was under the care of the consultant cardiologist Hugh Bain at the Freeman, who just encouraged me to do everything, which was a massive and that was obviously within tolerances, but he just encouraged me to do everything. So I went climbing in the North African Atlas Mountains at 8,000 meters. I played football. I did everything. But then in 1985, there was a sudden stop because the deterioration in the valve meant essentially they just said, we don't want you to do any more activity, or that's the way it was sold to me, or that's the way I took it. And that meant kind of I couldn't play football anymore. I couldn't I was in a rock band. I was playing drums in a rock band. I couldn't do that anymore. That was kind of all of that upper body activity. And that was a huge hole in my life, a huge hole. Over a period of the next 15 years, there was decreased mobility and activity when I had the opportunity to have a Ross procedure, which was done by Asif, which was remarkable and made a heck of a difference. Just out of interest, the way one of the markers I had for my decreased mobility was, currently I'm 133 pounds. My tracking tells me that just before I had my operation, I was 152 pounds. So I was in effect carrying 10 bags of sugar around on my body all day and every day. So it was, you know, there were huge impacts on that, and I wasn't doing anything like the more moving. I had the Freeman rehab process. I then switched to the local council's CHD cardiovascular rehab program, which I was involved in helping set up. And then for the past 21 years, I've been involved in maintenance, but now getting ready and prehab for whenever the inevitability of the next replacement. Next slide, please, Kay. I was thinking about how patients might feel, but I can't speak for other patients. So again, I'll only speak how I felt. And recovering from any health-related intervention as a patient is really scary. We feel fragile, which I think many people have touched on this morning, which was really useful. We feel fragile. We are concerned about whether we are going to be able to do anything active. But on the other hand, as congenital heart patients, I grew up with that. Just a second, Kay, leave that up a second. I live with that that inevitability that something was going to happen. I came to terms with that. I lived with this serious defect. I was told when I was 8 years old that by the time I get to 40, there would have to be some kind of serious intervention which might change my life significantly, which is a big lot of information to take when you're aged 8. I'm not entirely sure we would do that now, but so I've just got a next slide. The wonderful Prospero in the Tempest said, "Retire me to my Milan, where every third thought shall be of my grave." It's kind of those of us with, I'm sure not all I'm not speaking for all congenital heart patients. However, there is at the back of your mind, there's a thought of what might happen when this happens. There'll be something happening sooner or later. Next slide. And the other thing is, after the intervention, I felt betrayed by my body, and I was desperate to get back to what I considered to be normal. Do you want to give us the next slide? Yeah, John Dunn is a brilliant piece of work. I was involved. I'm from a public health background, so I studied health. I deliberated on what I ate. I thought about the exercises I did. I hewed and polished every stone. And in a minute, suddenly all of that was demolished. And I wanted to go back to and get back to being able to do the things I've always wanted to do. Next slide. And I have to say, I hated being in hospital, and the physios that are out there. Just next slide. Obviously I consider myself to be a celebrity, so I just wanted to get out of that hospital. And if the physio had presented me with some kind of bush tucker trial, I would have done it to get out of there. So I was desperately taking note of all of the things the physio was telling me to get out, to just simply get out of the hospital. So it's just worth remembering that we don't like being in hospital. We've been in hospital a lot. We don't like it, and we want to get out of there. Next slide. Yeah, and so the Freeman was presenting rehab, and one of the things I guess with adult congenital heart patients will be the span of the age groups. So the normal cardiovascular rehab process is often targeted at certainly all of the men's group that I was in. They were all what I thought was old men. Some of them might have been over 60. I never thought, of course, when I was 40 that I would reach the age of 60. Good. Next slide. And it brings to mind that the Monty Python, you know, I'm not old, you know, you don't assume I'm an old man. And it reminds me of what me and my friends talk about is a shifting threshold of in my father's day, 60 was old. 60's not old to me and my friends. It may sound old to all of you and who are watching this, but it's not old to me anymore. And I just had a talk yesterday about care homes and the shifting threshold, and currently the people who are in care homes and residential homes are the Mick Jagger generation. If I have to have the necessity to go into care, I'll be wanting to fight for my right to party. You know, that's what I want to be doing. And equally in the context of rehab, it needs to be age appropriate too. So what might, and so I guess we're getting on to the next one, which is about thinking. Could you do the next slide, please? Which is about it being bespoke. And because I knew the council's officer in cardiac rehab, who was doing CVD rehab work, who now works for the Swimming Association and has just received a whole bundle of awards for the work around health and well-being with the swimming industry, I got a bespoke program. And way back in the early 2000s, I was recommended to wear. He got me wearing a Polar chest heart rate monitor, and within that, yeah, there's a picture of me within. Yeah, next that slide will be great. I said nobody said it would be easy. That's my miserable face doing the coast to coast because it was hard, but I was so pleased I could do it. That was after having had 15 years of struggling up hills and just walking around and generally doing much physical activity. I was suddenly able to do that. So ignore the horrible face and ugly face and the pain that's on there. That's a huge achievement. And if you have a look, you'll see I'm wearing my heart rate, my Polar watch, which was way back into 20 years ago. So next slide. Just a little reflection, post intervention or whenever the rehab's taking place, it needs to take place when me as a patient's ready. Motivation's a huge challenge, and there'll be people like me who will be massively motivated to do stuff. There'll be others for whom it's very, very difficult. I think I've been really encouraged by the concept of everybody recognizing it's not a one size fits all. There needs to be some personal element to be that, and that the activity reflects abilities. And that's not just, and I will say this because I'm passionate about recognizing issues relating to people's abilities. I, for most of my life, have been sitting in congenital heart clinic, sitting alongside a number of young people with Down syndrome and other different abilities. That how that's presented to them. Just go back a bit. Sorry, Kate. Yeah, how we develop that needs to be carefully thought through. Again, wearing my public health hat, we've done an awful lot of work with families and people with those mixed abilities to talk to them about things like physical activity, about obesity and good nutrition, and about things like sexual health even. And we've done a lot of work, but that needs to be carefully thought through. So we need to think about those kind of issues. Is it being delivered by the right people? So is it we've picked up here that it is physiotherapists, is there with the right background and rightness. Like Caroline was massively knowledgeable. That's the kind of person that's needs to drive this. And then the final issue is the bit I talked earlier on about I'm trying to remember who I was with Lucy, which is about the mental health issues. And mental health issues have been the biggest challenge. So I can be physically well, and I am physically well. However, there have been at least 3 episodes in the first 15 years of post Ross where I've had serious clinical diagnosed serious mental health issues, traced back to dealing with the concepts of some of the things I've talked about. Next slide, please. And the final thing here is this, ignore those first three. That was me just posing a few questions about, and you've answered those for me today, is why people take up, are we clear why some people don't, can't, or won't? And it's about, you know, my public health back tells me that it's sometimes about time, and people don't find it really difficult, and there are huge barriers which we don't see. I'm a white middle-class male, coming from an affluent background. I find exercise easy to do. There are people who live not a mile away from me in nearest, deepest, darkest Jarrow who find that really difficult. The final point for me, and this is a key point for all of us in the congenital heart disease network, the patient reps, is about the demographics and making sure that we are doing the utmost to make sure we're meeting the needs of all of those people who need it. So we think about people with different abilities. We think about geographic issues. How easy it was. The Scottish one I was really interested in, because the Scottish program, Glaswegian talk program by Elaine Muirhead, wasn't it? She was talking about the geographic difficulties of the islands, and we have similar problems here in the northeast, don't we? How do we get somebody from Crook or Wellington or even Hartlepool? Hartlepool's a bad example, but some of those places that are remote in Durham, how do we make sure they are getting the you know, how do we make it easy for them? How do we make sure that's easy? Are there barriers for people from different ethnic backgrounds? Are they different from people with who are less educationally advantaged? So what are the issues? Do we understand what's happening? Why are people dropping out? Why are people being lost to follow up? How do we shape that information to shape a proper, effective rehab program? And I'm just posing these questions as a patient, but somebody who's really interested. And overall, like I said at the start, this has been a fantastic. Sorry, that's my phone. I should have switched off, shouldn't I? This has been a fantastic experience for me to listen today. But just remember about us all being different. When you've met one congenital heart patient, you've met one congenital heart patient. Thank you, Kay.